So welcome everyone to our citywide psychiatry grand rounds. It gives me great pleasure to welcome everyone here. I know we have a wide range of audience from all over the world and including Canada. Thank you for making the time. I'm really excited to hear today's presentation. I'm Raj Rasasingam. I'm the CPPD Director for the Department of Psychiatry. To begin, I'm going to do the land acknowledgement today, and then we will continue with the agenda. I would like to begin with an acknowledgement of the land in which we work, study, and live. Before I read it, I would like you to take a moment to situate yourself and think about the land under and around you. We recognize that many Indigenous nations have a long-standing relationship with the territories upon which the site the Department of Psychiatry is located and precede the establishment of the University of Toronto. We acknowledge our presence on the traditional territories of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat people. Today, this land is home to many diverse First Nations, Inuit, Métis people, and we're grateful to have the opportunity to live, work, and gather at these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with the multiple Mississauga and Chippewa bands. Since it's a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. So thank you. I'll talk a little bit about, at the end of the day, we will send an evaluation link, and please give us your feedback. We're always continually working on improving things. Our sincere appreciation to our two speakers, Dr. Jonathan Hunter and Dr. Robert Maunder, and Sinai Health for kindly hosting us today. And the next citywide psychiatry grand round is on the 26th, and it's going to be hosted by UHN, and it's on the topic of eating disorders. Now, I'm going to ask Dr. Vicky Sturgiopoulos, our Vice Chair of Clinical, to do the official welcome.
Welcome, everyone. We're thrilled to see you this afternoon, and we welcome you to come back every last Friday of each month to our hospital-wide grand rounds. With that, I will just ask Dr. Leslie Weisenfeld, Psychiatrist in Chief at Sinai Health, to introduce our speakers today.
Thank you, Vicki, and thank you to our citywide grounds planners for this opportunity for our community. My pleasure to introduce my colleagues, Dr. Bob Maunder and John Hunter. Fair to say they're unique colleagues in their own right, but in the spirit of brevity and also the passage in their latest book where Bob acknowledges how often they're confused for one another and how they're unsure who is responsible for their best ideas, I'll say a few things about them together. Both are full professors in our Department of Psychiatry. Their work is graciously supported by the Sinai Health U of T Chair in Health and Behavior and the Sinai Health Penser Family Chair in Applied General Psychiatry. Both John and Bob have really dedicated their careers to developing expertise addressing psychiatric illness, psychological suffering in a medical context where attending to the illnesses themselves, to the patient's vulnerability, and to the healthcare team's role in optimally mediating that suffering and fear and the discomfort really forms the basis for the model of care that you'll hear more about today. Our Sinai Health Department of Psychiatry is very grateful to Bob and John for representing us and our hospital, our health system at these rounds, so thank you to them in advance. And I think lastly, I'll just acknowledge that we appreciate how many people and patients are suffering from adversity and trauma, and how much we really hope as a broad healthcare community that we can stay committed to addressing their needs skillfully so we can offer comfort, better care, and better outcomes. So with that, thank you to John and Bob, and look forward to hearing them.
So thank you for my colleagues in this kind introduction. Bob and I are very pleased to be here today to have a chance to speak with you in this way. This is a little bit of an atypical citywide grand rounds for a couple of reasons that you've heard of. One is that it goes beyond the city, it goes beyond the University of Toronto, and it goes beyond psychiatry. We have colleagues from different walks of life and different parts of the world that are joining us today. The other reason it's atypical is because it concerns a book, the title page, which you see here, Damage, Childhood Trauma, Adult Illness, and the Need for a Healthcare Revolution. We're going to be talking about that book and reading some excerpts from it as we go through the rounds today. A contextualizing comment, because there are people that don't know us, I want to just emphasize something that Leslie said. Bob and I are consultation liaison psychiatrists. That means we are the psychiatrists who see people with medical and surgical illness and have psychological or psychiatric concerns embedded in that context. That is how Bob met Isaac, the person we're going to introduce you to today. So for the rounds, we're going to follow this outline, talking about the conflicts, the consent, and the voice. And we're going to read from the book to illustrate how childhood trauma contributes to adult illness and to try to emphasize the fundamental importance of relationships in medicine. When this goes badly, it turns doctors and patients into us versus them. Patients get defined as difficult, and healthcare workers get vicarious trauma. When this goes well, we have strong treatment alliances, patient-centered care, and true health equity. We're going to finish with some thoughts about what we can do to make it better, something that in the book we refer to as a healthcare revolution. And if our timing works out, we'll have plenty of time for discussion, which we're looking forward to. A content warning, this is a rounds about childhood trauma. It is upsetting, and we ask people to be aware of that. There is also swearing in some of the excerpts that we are reading. Both Bob and I will receive our royalties from the sales of this book, and in that sense, we have a financial conflict. And we thought we might as well just illustrate right up front that we are trying to persuade you that the healthcare system needs to change in order to improve patient care. The man we refer to as Isaac has given repeated explicit consent for this work, and he has even urged its publication. The names have been changed and details have been changed as well to obscure and protect his identity, however. Like many books, this went through several iterations, and we realized pretty early on that switching between we and I didn't work. So the voice you're going to hear, the narrator's voice, is the first person singular. I think most people hear it as Bob's voice, but the construction of the book is shared, it is co-written, and our perspectives are blended. So let me introduce Isaac to you. 5 years ago, Isaac wrote to me to describe the awful sexual abuse he had experienced as a child, much more clearly than he had ever managed to say out loud over 15 years of therapy. 2 years after the next session, in which we discussed the abuse again, I received another email. Hi, Bob. I was alone again, thinking in the car about how much I've had to inflict upon you over the years, perhaps now more than ever. I was also thinking that in the context of what we do, writing is an act of cowardice. Can't say it, so write it. It's the best I can do right now. For the record, you can do what you want with whatever I write. I want you to save what I've written, not for me, but for you. You can share what I've told you as long as I remain anonymous. Perhaps it will be good for both of us. I've always asked you for everything you have. No half measures. And once again, I need you to help me understand the damage that I am.
So now to continue to introduce you to Isaac and also to our relationship, which is close and complicated, I'm going to read you a passage that describes the first time we met. And this is from the chapter that is called Fucking Dead Weight, because that is something that Isaac's father used to call him. When Isaac first came to see me, I thought it was to get help coping with Crohn's disease. The psychiatrists at my hospital who treat people with physical illnesses had divided up the diseases between us, and Crohn's disease belonged to me. Crohn's causes the gut to become swollen, painful, and dysfunctional, sometimes for long periods, often unpredictably. It means days with dozens of crampy, bloody, urgent bowel movements, nights lying awake with fever, sweat-soaked bed sheets, and pain. It comes and goes, often with no pattern. It is an invisible disease and elicits very little sympathy. Isaac told me that parts of his intestine had been removed by a surgeon 5 times, each a few years apart. Usually, people with Crohn's disease take powerful anti-inflammatory drugs to control the disease. Some need surgery, but drugs are the mainstay. Isaac, on the other hand, wasn't taking any medication when he came to see me. He hadn't found it helpful. Instead, Isaac told me that he was prepared to manage his disease with repeated operations. I've done the math, he explained. Each time they operate, they take out 8 or 10 inches of intestine. The operations have been 5 to 7 years apart. My small intestine is 20 feet long. I'm 45. I have more intestine than I have years. Why take the drugs? The arithmetic was right, but I had never heard anyone speak of repeated major operations with such cold-blooded calculation. Isaac showed no hint of anxiety. He seemed to have a version of Crohn's disease that was resistant to the usual drugs, but it wasn't making him anxious, and as far as I could see, he wasn't depressed either. So why did he need a psychiatrist? From the start, I saw Isaac's strength before he let me see anything else, and his strength was impressive. It wasn't just the surgery calculation, although that would have been enough to capture my attention. He was articulate, intelligent, a bit intimidating. He held a senior position in a large labor union. We spoke only briefly about his work, but he conveyed his passion for it, and I had the sense that he would be a tough opponent in a dispute. His appearance reinforced the impression. He was skinny, but he didn't look weak. He wore a white dress shirt, a vest, a woolen tie, a pair of jeans that looked new, and well-worn cowboy boots. His gray hair was long and a bit unkempt. He had his own style. Isaac looked around my office. At a first meeting, people often look around nervously, but he didn't look nervous. It was more like he was taking his measure of me and waiting for his moment. And then, very quickly, he caught me by surprise and told me why he was here. I'm living in an empty apartment with a cot and a shitty radio. I moved away from my wife 3 months ago. I haven't bought anything for the apartment. I don't know if I'm going back home. Why did you move out? Isaac hesitated and then spoke. He had been sexually abused as a boy and had kept it secret from everyone, including his wife, ever since. He had recently broken his silence, telling his wife, Sarah, what had happened. Her response had made him feel so hurt and angry that he left their home to find some space to regain his equilibrium. He regretted having told her, but now, having opened the subject, he needed to talk to someone. I didn't know how to reply. Sarah had hurt him, and I didn't want to add to his obvious pain. I decided not to ask about the abuse. I asked instead what Sarah had said. Isaac explained that she felt betrayed. Learning that your partner has kept a life-defining experience from you through 25 years of marriage would shock anyone. But at that point, Isaac wasn't up to thinking about Sarah's perspective. Her response, that explains a lot, made him feel small and then angry. But the part Isaac could not forgive was that Sarah had told her girlfriend about it. I imagined that she needed some support, but Isaac saw only a circle of expanding humiliation, gossip and sideways looks that would say, that explains a lot. So from the first time we met, I saw Isaac's strength, and then I was invited into his most painful secret. He let me know that what made him feel safe was to be alone, by himself, with only a cot and a radio. But he also let me know that he could not survive without talking to someone. I was struck by the fact that he could be both a detached calculator of risks and a man so bound by shame. You could string a tightrope between those poles, so dramatic was the tension between them. In a sense, our conversations are about walking that tightrope, sometimes with grace, sometimes just clinging, trying not to fall.
So let's turn now to childhood adversity and child abuse and some of the factual knowledge we have about that to give you the context for this story. This work started by Vincent Folletti's group when they looked at the relationship of childhood abuse and household dysfunction to many of the leading causes of death in adults back in 1998. They used a scale they called the Adverse Childhood Experience, the ACE scale, which we put up here on the left. That categorizes adversity into physical abuse, sexual abuse, emotional abuse, emotional neglect, material deprivation, parental separation, having a family member with mental illness or with substance abuse, or who has been jailed, or being a witness of family violence. This is certainly not the only way to categorize adversity in childhood, and there's been a lot of work since refining the scale, but this is the item list that they used in their studies. Gilbert did a prevalence study in North America, looking at the rate of ACEs in the general population, and found that only 40% of the population did not have adversity in their childhood. Fully 60% of the population had one or more episodes of adversity. In fact, 1 in 3 children experience child abuse. This is Canadian data from our colleague, Tracy Fifi in Winnipeg. And you can see that although it varies by gender, fully 1/3 of the population has experienced child abuse. What Folletti's group did, which was profound for medicine in general, we hope to make the point, and certainly for consultation liaison psychiatrists, was establish a relationship between adversity in childhood and later adult disease. On this graph, you can see on the x-axis the number of childhood ACEs, ranging from 0 to 4 or more. And on the y-axis, the likelihood of getting a disease, in this case, chronic obstructive pulmonary disease. And you can see that by the time you get to 4 or more ACE events in somebody's childhood, they have 4 times increased likelihood of getting COPD. This is a dramatic increase in risk. And in fact, when the study was extended to other diseases, that dose response curve between number of ACEs and risk of adult disease was proven over and over again. Here's a list of a number of the diseases where it was shown to be in effect. And I'll ask you to read those for yourself, but observe that we're talking about diseases that account for tremendous morbidity, mortality, hospitalizations, healthcare costs, and untold suffering. In fact, people with 6 or more ACEs die nearly 20 years earlier on average than those without ACEs. Bellis makes the point that radically different life course trajectories are associated with exposure to increased ACEs, resulting in increased mortality. What do we know about mental health? We've put a lot of data on this one slide. Here you can see different diagnoses across the x-axis and different colored bars representing in blue physical abuse, in red sexual abuse, and in yellow exposure to intimate partner violence. You can see again that where there is adversity, there's increased risk of mental illness. This ranges from depression with physical abuse, a 2.5 times increased incidence, all the way up to suicide attempts, where in the presence of sexual abuse in childhood, there's an 8 times increased odds of the condition. Similar list as for physical disease. We see many of the leading problems we have in mental health these days listed here, all of them more prevalent. when there has been adversity in childhood or childhood abuse, accounting again for substantial human suffering. There is a third category, which I think is less on the radar for people in the general public, and that is the category of functional syndromes. Functional refers to physical symptoms that are hard to explain. The individual has a pain or a distress that they feel in their body that physicians find hard to explain in terms of typical tests and investigations. But patients come to doctors seeking validation of a biological diagnosis in this context. The healthcare provider usually prefers a psychological explanation. That leaves patients feeling invalidated, often dismissed, and it leaves the healthcare provider feeling frustrated and sometimes helpless. This creates a social and clinical predicament which represents a situation in which the meaning of distress is contested, and doctors and patients are often very much at odds with one another. And here again, we see the same kind of relationship where people that have burdensome physical symptoms are more likely to have higher ACE scores, as is the case with health anxiety as well. In fact, in this meta-analysis that was published in JAMA a number of years ago now, we see a number of functional disorders listed on the left, and we see that all of them are more prevalent in the context of sexual abuse, as shown by the squares being to the right of the red line. So this interaction between abuse and other disorders has led us to refer to childhood adversity as a cause of causes. It impacts on behavior. It creates physiological changes, changes the social determinants of health, influences how people interact with other people, creates different psychological states, and it gives the vicious circle between physical illness, mental illness, and troubling interactions with the healthcare system an impetus and push so that this becomes exacerbated and worse. When we turn to Isaac's story, let's take a quick look at how these links work. Isaac has post-traumatic symptoms and fear and has low social support. He almost certainly has pro-inflammatory effects of stress and social disconnection. And these states have led to him having communication and emotions that are difficult to understand. He expects to be invalidated. He expects to be shamed, which leads to mistrust. And he lives with chronic impulsivity and suicidality. When he interacts with physicians, he has difficult interactions because he's often triggered in a post-traumatic way that can't be understood by those that don't know about his trauma. This leads to a lack of collaboration with doctors in making medical choices. It makes it hard for him to participate in routine preventative care. And sometimes, because of his fear, he resorts to intimidation of healthcare professionals. His pain symptomatically is out of proportion to the physical cause, and he'll use the pain medication he's prescribed, not just for analgesia, but for mood regulation. All this means that Isaac has a low priority on his health and a high priority on being relieved of his tremendous suffering. An example of that is his smoking, which gives him psychological relief, but is bad for his physical health. This is the complex interaction of somebody with significant abuse and a physical ailment.
Okay, so now we're going to go back to the story. And in this next section, we will reflect on 3 different facets of how working with people who've experienced trauma, and in fact, practicing medicine, is always relational. So first, I'm going to read a passage about how intense it can be to address trauma directly. Then John will read a section about how healthcare workers defend themselves against this discomfort, the discomfort of getting too close, by emphasizing us versus them distinctions, in which we treat our own perspective as objective. And finally, we'll talk about how John and I use our relationship to break down this false distinction between us and them. And these are all from the chapter called You're in It With Me Now. In the first few months of therapy, I worked hard to keep up with Isaac's pace, even as I cautioned him to take his time. He described multiple events of sexual assault by the young man next door. He also told me about the onset of Crohn's disease. The belly pain, diarrhea, and fatigue that are typical of that disease started shortly after the assaults when Isaac was 10. He had no way of knowing that it was a second problem. It all blurred into one. Although Isaac had felt trapped, terrified, and wordless at the time of the abuse, the feelings he was sharing with me now were different. He had a desire for revenge that he could barely contain. He felt angry and hopeless, as if by sharing his secret, he had surrendered somehow. He felt humiliated, and when he talked about his disclosure to his wife, Sarah, betrayed. Although we focused on the abuse and the chaotic mix of emotions that went with it, he left no doubt that he loved his children, wanted to heal his marriage, and valued our growing relationship. The first time I saw Isaac cry, he was telling me that he just needed Sarah to love him. They started marital therapy, but when Sarah revealed some mixed feelings about reuniting, Isaac went full tilt in the opposite direction. He furnished his apartment, took a road trip for a month, and then another trip into the country after he returned. I imagine that Sarah might have seen defiance and rejection at that point, but what Isaac felt was despair. I'm fucked up beyond repair. I'm so damaged. Isaac agreed to try an antidepressant drug. He started reading books about post-traumatic stress disorder and about therapy. He was walking that tightrope between despair and hope, or between seeking connection and running away. Then he described his dreams. I am a blind man being led down the street by my beloved dog. I am not afraid. I have a body in a bag in the back of my car. I dig a deep hole and bury it. I want to look at who is in the bag, but I decide against it. I am tied to a chair. Another man is tied to a chair beside me. We are tormented by a third man who is wearing a ridiculous costume. I am in a dark room surrounded by shapes that swarm like swallows or bats. They look like bats, but they have big genitals. They swoop by my head, barely missing me. Then the swarm swoops up and plasters itself at full speed against the wall. The splatter of the creatures smashed against the wall makes a silhouette. It is your face. The hair on the back of my neck stood up as Isaac described the final image of the fourth dream. I offered Isaac this interpretation. I wonder if those dreams are partly about what it feels like to come to therapy. Maybe I'm just looking for positive signs, but a blind man who is led by a trusty dog could be an optimistic metaphor for that choice. The body bag seems like some kind of darker mystery. Maybe you're not sure if you want to go there yet. The guy's tied up? I don't know. I was silent about the last dream. Although it is common for people in psychotherapy to dream about their therapist, it was unnerving to have my identity formed from smashed creatures that seem mostly to represent sexual abuse. Although I didn't say it, I was aware that I wanted to put a positive spin on that dream too, to align myself with the smashing of the creatures instead of with the bats themselves. Isaac had another interpretation. The guy tied to the second chair is you. The bad things are you. You're in it with me now. You're another captive. I came to understand that he was right. His interpretation combined the two opposing forces characterizing much of our relationship and the growing trouble I was feeling about it. On the one side is how the relationship benefits Isaac. He needs a confidant and a protector, or just not to be alone. On the other side is Isaac's fearful expectation that anyone whom he brings into his world will become damaged. I already sensed that his fear held some truth. I didn't feel like I knew what I was doing. Things were moving so fast. I wasn't afraid of Isaac, but I didn't feel safe.
So let's turn now to how healthcare professionals deal with this. There is a very long tradition of healthcare professionals, especially but not exclusively doctors, maintaining distance to protect against being overwhelmed by human tragedies. This gets carried to an extreme when we professionals start to think and act as if we are actually different from our patients, as if the difference between us and them is anything more than expert training, and because we, unlike our patients, may not be sick, at least not at the moment. Today, trainees are encouraged to write notes in which what they see is called objective and what their patients tell them is called subjective. They are taught to use unnecessary jargon. For example, substituting has suicidal ideation, or worse, just SI, for is thinking of killing himself. The jargon separates them from those who speak plain English, and it distances them from their patients' experiences. We routinely read notes written by young doctors in which they report, as they have been taught to do, that a patient claimed X and denied Y, rather than just writing that X happened and Y didn't. Their default position is to not risk fully believing what they have heard. All of this is utter bullshit. A doctor's observations are just as subjective as a patient's, but from a different perspective. We have no way of knowing when our patients are telling the truth and when they are not, but they're almost always trying to. We will all be fooled from time to time, but the value of starting by believing is far higher than its costs. Beyond being nonsensical, distancing ourselves by distinguishing between us and them is dangerous for both patients and doctors. For patients, this distance, or in its extreme forms, objectification or dehumanization, devalues their actual experience or renders it irrelevant. When their childhood experience is the cause of their illness, distancing sets up a conversation in which the key to the puzzle is invisible or off limits. For doctors, fractured and impersonal relationships with patients contribute to ineffective practice and to burnout. It harms everyone.
Memory has a way of turning multiple events into one. So the things I think I learned about John's father at his memorial service were probably acquired over a longer time. In my mind, however, the service marks our transition from acquaintances to friends. John's dad was RCA Hunter, the esteemed chair of the Department of Psychiatry at the University of Toronto from 1967 to 1974. When he died in 1987, there was a large memorial at the university. I walked to the campus from Mount Sinai Hospital, where John and I were both in our second year of residency. I listened to my mentors speak with admiration about one of theirs. I learned that RCA was a bombardier in the Royal Canadian Air Force in World War II, shot down over Europe and imprisoned in a German prisoner of war camp, and that he didn't speak of what happened there. And I watched John cry as he tried to get through reciting his father's favorite poem, Yeats' He Wishes for the Cloths of Heaven. Had I the heavens embroidered cloths enwrought with golden and silver light, the blue and the dim and the dark cloths of night and light and the half-light, I would spread the cloths under your feet. But I, being poor, have only my dreams. I have spread my dreams under your feet. Tread softly because you tread on my dreams. John and I talk about these things now in a way that we did not at the time of his father's death. His father's war experience, RCA's influence on John, his parents' romance, which I recently learned about at his mother's funeral, John's losses, my dad's disappearance into Alzheimer's disease, the burden of his decline on my mother, the families of our parents and our wives' parents, all with their own aces, how these things creep into dreams and sometimes nightmares. Everyone has these stories, There is no distinction between us and them. And yet, even though I insist there is no distinction between us and them, when Isaac tells me, "You're in it with me now," my reflex is to pull back from that idea and find comfort in so-called objectivity, to think about his dreams, not to participate in them. Like all reflexes, it is a protective move. When we talk about it later, John tells me that in fact, Isaac nailed it. You're in. He wants you in, probably needs you in, but he's afraid for you. You earned your way in, and he's better off for you being there, but he's horrified by the prospect that you can be harmed like he was. You've done a difficult therapeutic thing here, and it is working and good for Isaac, but he knows what an awful place he's put you in. Hang on, buddy. I sit back and let my shoulders drop. Having John in my corner allows me to do better work with Isaac. Every doctor should be so lucky.
We're going to turn now to some of the other effects of childhood adversity, perhaps more subtle. Of all the ways that childhood adversity makes people sick and then makes it hard for them to get better, perhaps the least recognized is that early adversity plays havoc with storytelling skills. Trauma leads to narrative incoherence. I see it often with Isaac. It doesn't matter that he's intelligent and articulate. It isn't about that. His defenses against appreciating his traumatic memories interfere with sense-making. This form of incoherence manifests as incomprehension, as in the dozens of times he has asked, "What happened to me?" It's a plain question, not rhetorical, not metaphorical, and it leads to weird conversations in which I tell him what happened to him, which I have learned from him, only to find that it makes no sense. The facts seem to miss the point. This is incoherence resulting from a brain not working right, or as Isaac puts it, from having a brain that is fucked up beyond repair. I hope he's overstating the permanence of the problem. Narrative incoherence also manifests as a misunderstanding about the purpose of communication. This happens when I assume that Isaac speaks to be understood, to convey some information, when in fact, he speaks to feel safe. Sometimes people who maintain their safety and security by keeping emotional distance from others, as Isaac does, use a kind of pseudo-communication that allows them to participate in a conversation without giving much away. Often they provide conclusions without evidence or elaboration. For example, if I ask, "What was your dad like?" somebody will say, "Oh, he was a good guy. He brought home the bacon." Being provided with a conclusion tends to shut a conversation down. It does not invite further inquiry, but it doesn't really tell me anything about the father. In a medical setting, when a healthcare provider is asking questions to understand a problem, this style of communicating leads to a short and unilluminating conversation. If I ask how something painful feels, for example, the patient may say, "It's bad," or "It's not too bad," or "How do you think it feels? Just help me get this back under control." Communication that is the opposite of collaboration uses generalizations without examples, conclusions without evidence, statements without elaboration, and commands without context. Their point is to maintain distance. A patient like Isaac is not wondering what a healthcare professional needs to know to help him, or how well they are understanding him at a particular moment. He's in a conversation that feels dangerous. He doesn't expect it to go well. A good outcome would be that the healthcare worker figures out on her own what will help and then just does it. He wouldn't be here if he felt he had any other choice. Most other outcomes include disappointment, pain, humiliation, or conflict. He has neither the wish nor the capacity to tell his story well in this moment, and his medical care suffers for it. It is my job to help people tell their story well. All of the biological marvels of modern medical treatment have to wait until we finish that part. Think how this applies to the many adults who have experienced substantial childhood adversity, the more than 7 million Canadians and 60 million Americans whose health care is compromised by the consequences of fear, which interfere with telling your story well enough to get the best care. ACEs do not just cause disease and illness, they render illness indistinct and puzzling. They force healthcare providers to confront their own limited skills as interpreters of stories and collaborators in communication, roles that many healthcare providers don't even want, let alone are skilled in. They render the magnificent achievements of biological medicine irrelevant, at least for a while, as we try to piece together what is going on. A patient and I can't begin to use most of the tools of medicine until we have used its most fundamental tool, our relationship, to secure a base from which we can do our work.
So throughout the book, we tell Isaac's story and through it show how early trauma acts as a cause of causes of illness and disease through many paths, and how it complicates the relationships in which support and care occur. And in this final section, we talk about what needs to change, and we like to think of this as our manifesto. We address several different audiences here in the final section, one by one, starting with healthcare professionals and especially doctors, because that's the group we know best. And our message to our colleagues is that 1 in 3 of our patients has experienced serious abuse or trauma as children. It sets them up for illness and interferes with getting good care, and we don't know who they are. Operating in the dark complicates healthcare. It means that we're blind to what is going on when patients find our interactions aversive or have fears and memories triggered by their medical care, or require more support than we think they should need, or demand more autonomy than we think is good for them. We misunderstand their symptoms and we underestimate the impact of their health on function. And our own research confirms what has been found elsewhere, that outside of mental health and especially among medical specialists, doctors don't ask about childhood adversity. So at an individual level, the first thing we can do as healthcare professionals to change the status quo is to learn how to ask about childhood trauma. We've put a video online to show you how to do it using what we call the CARE method. It's easy, it doesn't take long, and the conversation usually improves our alliance with patients, and we would argue improves their healthcare.
We can't really talk about children without talking about parents, but neither Bob nor I are parenting specialists. We do think, however, that it makes sense to try to approach this in a targeted way so that there's a matching between need and intervention. There are proven resources that are available that can provide evidence-based stepped approach to enhancing security and validation and reducing harm. It makes sense that everybody gets resources to support developing secure attachment, programs like the Circle of Security. For parents that are at greater risk, time-limited individual support, such as the Nurse-Family Partnership for low-income first-time mothers, has been shown to be of direct benefit. Where there is more substantial adversity, focus coaching on providing responsive care, such as the ABC program, the Attachment Biobehavioral Catch-Up Program, run by Mary Dozier in Maryland, is an exemplary program.
So the next category is the broadest one. It includes all of us, and it addresses what we can do as citizens. And the starting point here is simple. The evidence is in. We don't need more. There are piles of roadmaps and consensus statements telling us what needs to change. And what we need now is public pressure that drives political will. The changes that are required for prevention of trauma in the first place, and secondarily for prevention of the harm that it does, are broad and expensive. I've listed some of the strategies on this slide, and if you just glance over that last paragraph, you'll see just how wide-ranging they are. And in the book, we say these strategies could compose the platform of the most unelectable political party imaginable, because as a bloc, they're enormously expensive. So it's helpful to reflect on the financial cost of child abuse. Careful estimates that use assumptions that guarantee that they are underestimates demonstrate the consequences of childhood adversity cost trillions of dollars every year. So beyond doing what is right, there's also an economic argument for investing in prevention. And we need to transform healthcare organization towards what is called trauma-informed care, which is a huge undertaking. It involves active collaboration with patients, education, and cultural shifts. And this is a roadmap provided by an organization that is ahead of the curve, which lays out the steps to get from what is called trauma aware, which is where our organization is right now, I think, to subsequent steps that they call trauma sensitive and trauma responsive, and ultimately trauma informed. It takes years, and it requires buy-in and engagement at every level. And of course, although Damaged is not a self-help book, it also provides some guidance to those who are affected and their loved ones while we're working on the revolution. But that's not our focus today. So we're going to finish off here with what we call our haiku, speaking to why we all need to get more comfortable talking about childhood adversity and trauma. And that is that to treat, one needs to be trusted. To trust, one needs to be safe. And to be safe, one needs to be heard. So we'll stop there, and we have some time for questions and discussion.
Thank you for this wonderful, thought-provoking talk and discussion, Dr. Maunder and Dr. Hunter. I think it really has made us think a lot, and the book seems amazing as well. So there's a couple of questions from the audience. I think one of them that you may have answered, but maybe just to clarify, what are some of the concrete things that hospital administrators can do to advance trauma-informed healthcare?
Yes, it's a really important question. And I would say just to focus on like the most concrete central steps that a hospital administrator can take at that level. The first would be to put developing trauma-informed care formally into the hospital strategic priorities. I may be naming that kind of document wrong, but what I mean is it needs to be a priority of the kind where there are people hired to advance that, people charged with that responsibility, and where there's actually accountability and reporting required, so that there's ongoing accountability for how they're moving forward. So I think that's important. I would say engage patients and families from the beginning in a meaningful way and not in a token way. The third suggestion that I would make, it would be to get broad engagement from the various disciplines and areas of the hospital, and not allow this to kind of be left to psychiatry and well-being and particular areas of the hospital.
Thanks, Bob. So a follow-up question we have from the chair of our department. Did mention it was a really good presentation. The question that he had was, just give me 1 second. It has to do with the interface between nature and nurture, genes and environment. And he would like you to talk a little bit about that and the resulting therapeutic model. For example, in depression, if ACEs triple the risk of lifetime depression, this means that 15% with ACEs would have lifelong depression, and conversely, 85% may not. How would you talk about prevention in terms of in terms of this aspect?
you want to go there, John?
I'm not so sure I'm in a place to talk about prevention. I think the treatment message is in some ways quite traditional. We would understand that ACEs are an epigenetic impact on individuals. They change the biology of the brain, and that we have to be conscious of that and thoughtful about that in our treatment. But in order to access that brain, if I could put it that way, we need to have a relationship with that person. And in order to have that relationship, we need to be thoughtful about their psychosocial context and their psychosocial history. So it ends up being, I think, a plea for biopsychosocial integrated treatment in depression, as in many other disorders.
Thanks, Sean. There's another question, very interesting question from one of the audience about compassion fatigue, and how do providers kind of prevent themselves or help, how can they deal with that piece?
Yes, that's a really important question, and one of the reasons why we want to focus on the kind of relational aspects of providing care and being a healthcare provider in a multifaceted way, and not always kind of narrowly looking at care interactions between a provider and patients, because all of the relational aspects are important. And I think in our experience are crucial to maintaining your own well-being while doing work that is really hard. And I think that one of the things that we try and address in the book is that there's a misstep that we all make, I think, from time to time as healthcare providers, which is to think that if we kind of wall off the distress and fatigue that we get from doing healthcare work, not just with patients with trauma, but it's like especially acute in that situation. If we just kind of wall that off and keep it to ourselves, it actually makes it worse, right? So that's worse for us, and ultimately becomes worse for our patients. So that breaking down that us versus them distinction is not just good for patients, it's good for us, right? And the example at hand is that John and I are both psychologically healthier people and better doctors because we have a chance to talk about what we do with each other.
Thanks, Bob. There was another question about how patients can how they can play a role in to make trauma-based care part of their treatment plan. Any thoughts on that?
Yeah, that's a super question as well. We would encourage patients, if they feel safe, to speak with their healthcare providers about their trauma and how it's affected them and what it means for their pursuit of healthcare. In the book, we detail some of the sort of typical ways this plays out, where some people who are traumatized might withdraw from disclosure, withdraw from care, and end up presenting late with a significant illness. Other people might amplify distress and have frequent presentations that in a different way undermine the efficacy of their healthcare. It's a difficult thing to ask people that feel vulnerable to reveal some of this stuff, but we have found that where patients can bring this to their healthcare practitioners, most of the time it ends up driving the alliance forward and creating a better context for the healthcare.
I think the one thing I would add to that is as a kind of shortcut to starting that conversation, one of the things that we've done is to put an ACE calculator online that allows people to kind of calculate their own ACE score and then get a little printout. And it's not the score that matters so much in healthcare as the conversation, right? It's like it's the meaning of it all, and being in a place where it's safe and comfortable to talk about it. But having a score and a piece of paper is a way to start a conversation sometimes. So there's different ways to kind of introduce the topic if the healthcare providers are not introducing it themselves, which we all should be.
I might add one very quick point. one of the first things a patient should do if they want to have this conversation is tell the physician they need more than 10 minutes.
Thanks, John and Bob. So there's another question about curriculum in terms of integrating trauma-informed care and resiliency to practitioners in the medical curriculum. And, and your thoughts about including interdisciplinary teams of educators in terms of training. What are your thoughts in terms of medical education, resident education, in terms of this aspect?
Yeah, it's crucially important, and I mean, we all know that real estate in the curriculum is very expensive, and so that it's always difficult to add more things to the curriculum. But it's not just the information. I mean, the knowledge needs to be there, but a kind of a relational trauma informed approach is even more important than kind of developing the knowledge, and so. Interdisciplinary collaboration and learning from patients and families could occur a lot more, I think, in the early levels of the curriculum, particularly around these sorts of issues than it does currently. And I would put in a plug for and then maintaining the focus throughout training, because there's good evidence that empathy decreases over the course of our training particularly of medical students. So we bring in good people and we do a lot of good work up front, and then don't necessarily reinforce that through the culture of practice as people go through residency.
I'm going to, if I can, just jump in and reinforce that last point. Really, the theme of this book and the theme of the presentation is the intersectionality. If we treat people about trauma and they deal with trauma patients as if they're just trauma patients over there with nothing else, that's not the point we're trying to make. The point we're trying to make is that trauma is embedded in the general hospital. Trauma is embedded in the Crohn's clinic, in the cancer clinic, in the cardiology clinic. And so when it comes to curriculum, what would be ideal would be to have cases in cardiology where there's a patient with trauma, and you can't treat them the usual textbook way because of the presence of the trauma, and truly get it integrated in that way. I see we're close to the end, and I want to pull rank to say one more thing, which is to articulate a thank you to Isaac. This is a very brave act that he's done by letting us do this, and we appreciate it.
Yeah, thanks, John. Bob, we are getting close to time, so I think you have shared your emails and contact information. If you want, you can put it down here. If people had some other questions they wanted to follow up, there were some questions about ACE and different types of ACEs and how it impacts people, and so maybe they can directly reach out to you. Thank you again for this wonderful talk, and it was amazing, and I can see the feedback. I don't know if Leslie wanted to say a couple of words as well before we end today.
No, I'm grateful for the work and agree that we all have a lot to do to respond to the call for revolution. So it's really good to be together as a community to talk about that. Thank you.
Thanks, everybody.
Thanks, everyone, for joining us, and hopefully we'll see you in a month for our grand rounds from the UHN site, eating disorders. Take care.